Welcome to the Pediatric IBD Digest, the podcast focused on pediatric inflammatory bowel disease, Crohn's and colitis in children and young people.
We as your hosts, Dr. Tracy Coelho and Dr. Chris Bakewell, discuss clinical care and emerging research on select topics to support families and professionals alike. Please remember, the views shared are educational and do not constitute medical advice.
Welcome back to part 2 of this special mini-series with the one and only Professor Dan Turner. If you haven't listened to part 1, please do go and listen to Professor Turner's insights into IBD treatment in children. As always, I'm joined by my esteemed colleague, Dr. Tracy Coelho. Tracy, what were your highlights from part 1, just to entice our listeners?
Everything was great. For me, the tastiest highlight was definitely the whole food, tasty and healthy bit. A proper 5-star takeaway. Honestly, I left part 1 feeling both intellectually nourished with really delicious stuff and of course hungry for more.
So for this episode, we're moving away from what I would call standard therapy in IBD, and we're advancing into the murky world of combination biological treatment, or as it's termed, advanced combination therapy, ACT. It really is a bit of a brave new world. I remember hearing case reports maybe as early as 2022 documenting some of these patients in European centres receiving dual biologics, especially at the ESPGHAN meeting. Tracy, do you have any experience in this? Is this something you're doing?
Well, I wouldn't call it experience, but if you recall, I did float the idea at our MDT recently for one of our complex patients. And you'll remember the reaction. Palpable nervousness everywhere. The walls flinched. Someone stopped breathing for a few nanoseconds. Honestly, it was as if I had announced I had found a second moon.
Yeah. So with a lot to get through, now feels like the right time to reintroduce Professor Turner. He's world renowned for his work with pediatric inflammatory bowel disease, and he's a member of the Porto IBD working group. So, Professor Turner, welcome back to the podcast.
Dan, it's a real pleasure to have you back.
Pleasure to be here.
Chris, I'm conscious we've got a mountain of questions and not much time. So I'll skip the appetizers and head straight to the meat of the podcast, or what I would call the red meat of IBD, the controversial cuts. The main course being advanced combination therapy, or ACT. Our listeners are likely to be familiar with the traditional combination therapy in IBD. For example, pairing biologics with thiopurines, which we have already discussed in the previous episode. With ACT now emerging as a distinct strategy, Dan, could you start by explaining what exactly is advanced combination therapy in the context of IBD?
Advanced combination therapy, what we used to say biologics, but now with the small molecules and the different mechanism of action, the terminology is changing, so it's easy to say advanced therapy, but it's more or less what we previously called biologics, and still calling many of the small molecules biologics for the sense of ease of terminology with our patients.
Thanks, Dan. I don't want to dilly-dally, we've got a lot to get through, so can we jump right into the science? Broadly speaking, of course, there's lots of nuance, but what are the mechanistic or immunological principles that underpin this advanced combination therapy using two biologics together?
One, I think it's before you go into the science and the molecular side of the of what is happening with the dual biologics or dual advanced therapy, it's just intuitive to assume that if you take different treatments with different mechanisms of action, so you have an additive effect. And the additive effect does not necessarily mean that 1 + 1 is 2. It could be 1 + 1 is 1.5 or 1.7. But what we are trying to combine in order to get 1 + 1 = 3. So is there any synergistic effect of both treatments? So not necessarily we need to aim for synergistic treatment, because additive benefit is also intuitive and very welcome. One of the, if you're thinking about the biologic mechanism that supports combination of advanced therapy, when one example will be anti-TNF and anti-IL-23, and there are studies both from animal models and from cell cultures, that the shared mechanism of genes expressed from cells are significant between the two treatments, but there are significant differences in patterns of gene expression, whether you give one of them, you give you give one of them, you give the other, or you give in combination. So you can really see that there are some genes that will change only when you give the combination, and will not change if you give either them alone. And that means that, and there is all kind of scientific pathways, which is not my expertise to discuss, to explain why and what this signature is driving. So I think now we are trying to be a bit more scientific about the combination, but truthfully, we don't even understand what one drug is doing in all the network of the multi-omics in our body. And there are many studies looking at the differences of metabolomics, proteomics, and we're still trying to understand one drug. I don't think we can assume that we can really predict what's happening with 2 or 3 drugs. So what we can do is just trial and error. You take drugs, you try to get the safer drugs in the combination. You try to look what is the effect, what is the safety. But with that, to do a lot of studies and to take the multi-omics and to see what we are changing, and from that to learn backwards of what has been the right combination. And it's possible that the right combination will vary between patients, and that part of the personalized medicine that we're pursuing, that like the holy grail in the last 20 years, but we are not, unfortunately, near to that goal, despite endless a number of publications on the field.
Yeah. And am I right in saying that this is what we're talking about here is refractory IBD? These are patients who haven't responded to conventional treatment with biological therapies that are needing additional support with that.
I might challenge that concept, at least for future thoughts, that possibly if we're talking about Crohn's, not ulcerative colitis. I said ulcerative colitis, as I said in the previous podcast, that ulcerative colitis, the effect of biologics does not change with the disease duration. So it means that if you give the treatment now in 1 year time, the same effect. So there's no really reason why not to do a step-up approach, 5 thiopurines, 1 biologics, and it doesn't work. You give 2 biologics. There's no added benefit of starting hard in the beginning like the VIGA trial. However, in Crohn's disease, the disease duration is a very relevant factor in the long-term outcome of the treatment that we give. So there is a merit in treating hard and getting the disease under control. So I'm not advocating it now. I don't do that in clinical practice, but I envision that this is something that we will discuss in the future once also the cost of these treatment will decline, since some of these most severe patients, instead of, as I said previously, to combine anti-TNF with thiopurines, let's combine anti-TNF with risankizumab or ustekinumab, for instance, and only after the patient is going into complete remission and maybe extend the treatment target at transmural healing, histological healing, only then you de-escalate and you stop one of the drugs. And maybe that will be the next strategy. Now, I have to tell you that when G. Markovich started this top-down thiopurine trial, it took him 4 years to enroll these, I can't remember how many, 70 patients that were in the trial, because it was so revolutionary that to start thiopurine from the outset, that was not the case. They started 5-AS, saying doesn't work steroid, and only the 3rd time they started thiopurine. That was the strategy. And I remember when I was a fellow, it wasn't too long ago, a little bit more than 20 years ago, and Anne Griffith told me, she was my mentor, let's plan a study that you give anti-TNF. And it just started, the infliximab was just starting and getting into treatment. He said, let's start giving infliximab from the outset to all patients, see what happens. And I remember I told her, and nobody will give it, nobody will join that study. It's crazy. And here we go. So I think that we are heading to a situation that we will tailor more than one drug in some of the patients, even without them being fully refractory. Acknowledging that the combination of advanced therapy did not break the glass ceiling of our treatment. So still, you get an added benefit, but it's not a miracle.
Yeah, but it's generating a lot of interest. I mean, in the last few years, it's been talked about more and more. Fair to say, evidence base is still slowly developing, and you were the lead author, or key author in the double PIBD study, which is 2023, I believe, and that was from Espegan, the Porto IBD group. That was a landmark study, giving most of the pediatric data we have so far. Would you be able to walk us through that study and what we've learnt the other end of it?
So this is another Porto Group initiative, and I will just open brackets here and tell everyone you can join the special interest of Espegan on IBD, and then all these initiative and using collaborative effort of all the different centers is open for all the I think there's like 150 or 160 sites now in the special interest group, and then you can do a lot of these collaborative studies between the centers. And that one is led by Anat Yerushalmi, and there were numerous sites that contributed patients. All in all, there was roughly a little bit more Crohn's disease than ulcerative colitis. There were 60 or 70 patients in that trial, maybe 62 patients, if I remember correctly. The issue is that, like most of these retrospective studies in adults on pediatrics, the heterogeneity of treatment was huge. So it was all over the place. People combine everything with everything, and it's very difficult with very different disease duration and background stories. So it's very difficult to get a very clear understanding of the real effect in the specific patients. But you know, after that trial of the Porto Group experience, there were, I think, there quite a few publications. Otherwise, there's at least 70 or 80 children that were published in the different case series and cohort with advanced combined therapy, and that adds to 200, 300 patients that were included in meta-analysis in adults in retrospective studies, and all showing more or less the same. They're showing that clinical remission in these most refractory patients, 50 to 60% enter clinical remission, and that's about between 6 and 12 months from induction, and roughly 25 to 40% of patients, depend on the publications, but this is also the result of meta-analysis in adults, reach biologic remission and even endoscopic healing. For children, many of these children will start growing, and they definitely, this is a game changer for them, especially those who are not eligible for surgical resection. So there's really not much to do with these patients that are so refractory and are in agony. So for us, the combination of advanced therapy, or as reflected in the publication, was really significant for many patients.
Thanks, Dan. So many of our patients struggle with extraintestinal manifestations where the disease activity doesn't always mirror the gut inflammation. In your view, I know the evidence base for this is scant, but as per your clinical judgment, what role could ACT play in managing IBD that is complicated by extraintestinal manifestations?
Definitely, extraintestinal infestation is a significant part in the decision of advanced combined therapy. Because it's the easiest way to get it approved by the funders. So if you have IBD and the IBD is controlled by ustekinumab because they failed, for instance, anti-TNF, and then the arthritis is flaring because ustekinumab is not a great drug for arthritis. Then you can say, okay, I have this for the lumen. Now I need something else for the arthritis. I want to go back to anti-TNF because anti-TNF was very good for the arthritis. And here you go, and you have ACT approved and clinically justified. And that's one. I would call it half excuse because it's not really an excuse, but it's easy to get the funding this way. Other things can be when you do have treatment that are partially controlling your gut, or fully controlling your gut, and you don't want to change them, but something is happening outside. So it could be you're giving anti-TNF with psoriasis, but you tried previously to move away from anti-TNF, and the drug and the disease always flares. So the only thing that kept the luminal disease under control is the anti-TNF, but because of psoriasis, you want then to combine it with ustekinumab or anti-IL-3 or risankizumab or whatever, and to see if that works. The same thing goes with upadacitinib when you have a multi-autoimmune things that is not fully under controlling what you want to give, or you want to give vedolizumab and even perianal disease. So vedolizumab, for instance, is the only thing that works for the lumen. We know that it works a little bit for perianal disease just because it reduces the inflammation in the rectum, and that also sometimes improve a little bit the perianal disease, but you will need something else for that disease. So if you have a different indication, that's the easiest way to choose which advanced therapy you want to combine, and also, as I said, it's the easiest to get approval.
And again, as I mentioned before, I like to throw very prickly pearls in the conversation sometimes. So what happens in the research world may not exactly mirror in the real world. So how often do you find yourself using ACT in your own clinical practice or within your own unit?
So we use it. It's not rare. I mean, it's probably less than 10% of our patients, maybe 5% of the patients, if I need to think about it. But they're changing, because we don't keep on advanced combined therapy all the time. We try to de-escalate after 6 months, 12 months, a year and a half. And often we can, but sometimes we can't, and we just keep them. We have patients that's what they're getting. So that's good. And you know what? Mostly you get at least a response. I cannot think in the past few months or year one case that we started it and even that completely failed. What we sometimes need to do is to change which treatment we're giving. So you give 2 drugs and it doesn't work, so you switch again, you switch both of them until you find a combination. You optimize treatment. So you take level of the anti-TNF, you increase the levels, usually, you know what, I have one kid in mind that it didn't really work, all of it. And it's really, and then you think about all the options for the refractory Crohn's before we used the advanced combined therapy that we had prior to all this a wealth of biologics that we have now. So thalidomide and Balresc and sirolimus and all these things that we tried to do previously.
Thank you, Dan. That's really useful. So now moving on further into the unknown, we are all aware that with any of these immunosuppressive medications, there's always a risk of immunosuppression. And with dual therapy, the risk is theoretically even higher. So is there any update on the safety profile of ACT? What do we know about the infection risk or other safety signals?
So it's difficult to draw a definite conclusion. I think that will be an honest reply. But having said that, if you look at the meta-analysis of coming from adults, and there were a few meta-analyses, at least 3. The most recent one was published in IBD in 2025. There were adverse events. Probably the highest rate was if upadacitinib was combined with any of the biologics. If you looked at the retrospective case series in children, including the Porto group experience, but not only, there were adverse events. There was a couple of septic arthritis. There was venous thrombotic events. And it's very difficult to understand because these are the sickest patients, very refractory patients. Would they have the same safety concerns otherwise? Because there is right now there's no proper control data. Maybe the only proper control data there is it's in ulcerative colitis with the Vega trial. Which was a double-blind RCT that compared golimumab plus gocilcumab as a combination to either alone. But in this study, after the induction therapy, there was de-escalation to one only to gocilcumab, and it was not in refractory patients, but it was at disease onset, and there the safety was okay. Another prospective trial to quote, but it was not controlled, is the Explorer open label trial. They gave triple therapy with vedolizumab, adalimumab, and methotrexate, 55 adults. Again, it seems like the outcome was a little bit better, and that's still new onset Crohn's disease, but the safety profile was okay. Definitely, I think what we are pushing, and this is part of our guidelines as well, that if you're going to use it, at least one of the biologics need to be a safe biologic. And safe biologics, I mean, or ustekinumab or anti-IL-23 or vedolizumab. And then I usually, unless there is contraindication, combine anti-TNF because it's a very effective medication, maybe the most effective medication we have today. And I try not to combine with upadacitinib or tofacitinib, which carries probably more safety concerns than other biologics, both for malignancy and VTE and other issues. But if you combine upadacitinib with ustekinumab or risankizumab or vedolizumab as a second-line combination therapy, I think that's reasonable.
Yeah, it's interesting. I was just thinking the logistics. It's a shame. Obviously, the safety signal is really important when you're thinking of such sort of therapy outside of established guidelines or even evidence, because the combination of an infusion with an oral small molecule feels attractive, but actually clearly the early signal is maybe that's not the way to go. Can I just kind of pick your brain in terms of the thought process of when you're starting the dual biologic? Because presumably, I mean, this is separate from what you talked about, where there's two mechanistic reasons, like you have an extraintestinal manifestation. So you want to treat the psoriasis and the luminal disease, or you want to treat the arthritis and the luminal disease. Then the choice becomes reasonably clear because you'll have a treatment for the lumen and you'll have a treatment for the joints. When you're speaking about refractory inflammatory bowel disease, luminal disease, and you're choosing two biological therapies or advanced therapies, presumably you're reaching the end of the line in terms of single biological therapy, then you're going back to choose two therapies. What strategy do you have for doing that? You've kind of teased it a little bit there. Are you going straight back to TNF and thinking logically what should go with it? Is that the way to go if you were going to?
Yeah, so I would say that usually you don't have zero response to any treatment that we give. It's not black or white. I mean, mostly you give it a treatment and you get some effect, but the effect is not sufficient. That's in most cases, especially with anti-TNF. Very few have zero response. Even if you look at the REACH or Imagine or other trial, it's about 15% of cases. And then that's an easy gain because, as we said, you get what you get from this one, you get what you get from that one. And in the bad scenario, you just got an additive effect. And in the good scenario, you got some synergistic effect. In reality, even those not responding well to one drug, if you go back and you do that with a combination therapy, you do gain response. You see that very often. And that definitely should not preclude going back to one of the biologics and using it. And I think with time, you need to decide when you de-escalate which one you want to stop. That will be also based on the history. Often it will be easy because if you are now giving a medication, then you're going to add something else on that medication. And rather than stopping it and trying to gamble on something else. So that's usually a more practical thing. You're giving what you're giving, you got a partial response, it's not good enough. Choose something else that you've done before, because otherwise probably you're going to switch to another medication anyway. Add one, and if that doesn't work, stop what you've done before and change for another advanced combined therapy. And that's usually in practice, that's what's happening in patients.
All right, thanks. A slightly different scenario. Let's say a patient is started on 2 biologics. Is there still a role to add an immunomodulator such as azathioprine or other to reduce immunogenicity? What's your take on that?
You ask me questions that there is no answer to. Your guess is as good as mine. All I can quote is again the Explorer trial that did use exactly that. As I said, there was two advanced therapy and one methotrexate combined with that. It was not controlled with or without methotrexate, and it has a Bayesian approach. Or what is the probability that it was better than placebo, either drug alone compared to historical data, and it was 99.9% chance that it was better than placebo, and I can't remember exactly, but 86% of better than vedolizumab and 70% better than anti-TNF and methotrexate. So I'm not so concerned of adding immunomodulator for safety wise if needed, if these patients are really sick. In practice, I don't think any of us are doing it. Even when I started upadacitinib, and because of the safety issue, most of us will stop immunomodulator. Not only because there's no evidence that it adds any benefit, it's also because we're concerned about the risks, and why add to it if you don't have a good data to suggest that you need to add it. And that's, I guess the same reasoning goes also for advanced combined therapy. If we don't have good reasons why to add a third one, then I'm not so sure it's justified for the potential added risk.
I'm sorry, some of our questions sound like BBC hard talk. I know there's no evidence at all, but
well, they're going to keep coming, I'm afraid. way beyond the evidence of the research. But okay, what about therapeutic drug monitoring? We've heard time and time again on this podcast, Professor Russell and a friend of yours from the Porto group, about how we potentially underdose children initially with our doses, especially with the anti-TNF therapies, and maybe we should be maximizing those doses. Is it acceptable to run lower levels of these biologics if you are combining therapies, or do you still go for levels in the therapeutic range, do you think?
No, the real thing. That's not immunomodulator as thioporins with anti-TNF story. These are the most refractory patients. I don't have many other tricks to pull from the sleeve. I want these patients to enter remission. We feel very savvy in optimizing treatments. So the optimizing treatment is not only level with anti-TNF, it's also if I get partial response, I'm okay to give vedolizumab to reduce it from 8 weeks to 4 weeks, or ustekinumab to go down from 12 to 8 to 4 weeks, and to do what we can to increase the likelihood for this to work. Because in the few cases that combining all treatment don't work, it's very challenging, and if we got to one step before the falling down the cliff, you want to ensure that you're doing everything you can for these patients. So definitely optimize all treatments you're giving in the advanced combined therapy.
Thank you.
Coming to further practicalities, coming to the cost. Now, biologics and the new small molecules, these are all very expensive drugs. So beyond clinical considerations, we got to convince our commissioners. ACT obviously raises inevitable questions about cost and resource use, something health systems are increasingly scrutinizing. So from your perspective, how do you see the cost effectiveness debate evolving as ACT becomes more and more visible?
Yeah, well, now that's not an issue anymore with the biosimilars coming by. So you can take now anti-TNF biosimilar with ustekinumab biosimilar, and it costs less than many other treatment that you give. It costs less than just giving risankizumab or upadacitinib. So if I were the regulator, I would say go on combined therapy of biologics and don't start with the new one that costs double, even if you combine the two drugs together. So I think that we have good case in the most significant patients, but we will have better case, again, as I said in the previous podcast, to think about cost as well. And if we think about cost and we don't position ourselves as combative to the people that need to make hard choices in the regulators or the insurance companies, because they have to make hard choices as well. If we work with them and we say, look, these are the most severe patients, we can give and prioritize biosimilar, then that's a cost. But on the other hand, look what will happen to these patients if they need to repeated admission. There is surgeries. Let alone the poor quality of the family and missing work and school days and what that means to society, and the suffering of the patients and the suffering of the parents. You put all of this into consideration. You show that this is only 5 to 10% of your patients anyway, and we are, as pediatrician, we care for patients that on average are more intensive, more severe, and have more extensive disease than adults. And this is very sensitive population. So usually these discussions and these arguments are convincing enough. But in order to be convincing, we need to talk the same language and discuss also the concerns that regulators may have regarding cost. And if we do that, then we have common grounds for discussion. And I found that very constructive where I come from.
Thanks, Dan. You'll be pleased to know we'll soon stop asking you such difficult to answer questions. But before we do, de-escalation. So it's unlikely that dual biological therapy will be a permanent solution for patients. I mean, to be fair, maybe in their pediatric years, but when they're an adult, not so much. You've started patients on dual biological therapy, as you've said. How do you approach de-escalation? Which treatment do you de-escalate first, and at what point do you de-escalate?
Very, very individual. It's very heterogenic. It all depends, and again, it's shared decision making with the family, acknowledging the limitation of what we can say. We need to be very honest and transparent to the family. Families appreciate it. You know, those who are reached the point of advanced combined therapy, they have seen it all. And they went through weeks and months of suffering, plowing through the different options of advanced therapies. So you can trick them, you can fool them. You sit together and you think together. Often the family will tell you, you know, I think that when he was on that drug, he was better. It just sensed better to me, and the feeling, the gut feeling of the parents and the patients, often more accurate than doing a PUCI or a weighted PCDI and just showing graphs on our charts. And then we decide what was our bet for the best drug that was before, and that's now. you put into consideration of these decisions preference of the child. If one is oral and one is subcute, and he prefers the oral, you stop the subcute if there is no good reason why otherwise. The same thing for IV or subcute, or once weekly, or once every 8 weeks. So there's a lot of consideration going on. I will try to de-escalate after a year, more or less, but I will need to be convinced that the disease is really under deep control. And if it does, sometimes it doesn't work, and sometimes the risk was really high, I will not de-escalate. I have a patient, she's now 12. I started the advanced combined therapy when she was 9. She has panenteric disease, stunting, and albumin of 2.8. We just couldn't get rid of that L4B extensive disease, and only after combined therapy she went into remission. She started growing, albumin is high, and she felt okay. The encapsule endoscopy before de-escalating. So every treatment change, you have to evaluate the disease before then with endoscopy. In this case, it was capsule endoscopy. She still had quite a few erosions, and here and there also deep ulcerations, and there was already 1 or 2 stenotic parts in a small bowel. I will not de-escalate that patient, and she will stay on these two drugs. And I wish I had maybe in the future this patient will get a third one.
That's our next podcast. Okay, so looking to the future then, sort of a lot of chat, and you've obviously given us a huge amount of really helpful information about this fairly novel approach to treatment. Are there any upcoming trials or ongoing trials, pediatrics or adults, that you're particularly excited about with respect to this dual biological therapy?
Okay, fair enough. I'm not so sure about pediatric trials that I'm aware of, but maybe that's a nice platform to call for one of these initiatives for a prospective clinical trial. But I guess these driven mostly by adults right now, and driven also by pharma that are trying to maximize marketing potential, which is great. Because otherwise, although speaking a lot about the cost, if pharma companies will not benefit from the drugs, then we will have nothing to give to our patient beside leeches and nutritional therapy. So we need to work with the pharma, and pharma have interest here to expand their marketing, and this is great. There's one upadacitinib with IL-23, which is a couple of these trials are ongoing, and that's exciting because presumably for effectiveness, IL-23 and upadacitinib seems very effective in Crohn's disease. Remains to be proven if better than anti-TNF, because right now there is no such data, but I would not be surprised if this would be the case. I'm interested to see as I said, the safety profile of taking upadacitinib as a first-line advanced combined therapy. There's a couple of studies of nutrition therapy with, and I said combined therapy of now it's not advanced, but it's still combined, and that should consolidate better our options. So I think there are few studies now that will help us shape our thought around which are the best candidates, what to tell our patient, what to expect with every specific combination. Only prospective trials can give us that. And the next few years will be exciting by several findings that will be published, and definitely what I'm saying now will change if you'll invite me again in 3 years' time on the topic.
Dan, we have had a fantastic time navigating these complex IBD topics, some supported by very little evidence, and as expected, you steered the conversation with the calm precision of a true mogul in IBD care. So thank you for your patience, your time, and the tremendous insights you have shared throughout this episode. We very much hope you'll join us again for future episodes, not in 3 years, but very soon. After all, we know now who to call when the evidence runs out and the opinions begin. Thank you so much for joining.
Thanks, Dan.
Thank you so much for the invitation.
It's a pleasure. Thanks.
Dear podcast buddies, we hope you enjoyed this episode on the marriage of biologics. From your own perspective, of course, always respecting the diversity of views. Perhaps some marriages really are made in heaven, enduring, steady, smooth, and relapse-free. If only all partnerships were that simple, especially when it comes to advanced therapies. Thanks for listening, have a great day, and we'll catch you soon for the next episode.